Discover the next level of critical care expertise with the Intensive Care Nutrition Fellowship, a phenomenal program for aspiring professionals in the field. With the increasing importance of nutrition in critical care, this fellowship fills a crucial void in training. It's not just a program, it's a deep dive into advanced clinical nutrition knowledge. The fellowship covers everything from basics to advanced concepts of nutrition for adults, children, and newborns, tackling questions about various critically ill patients across different specialties. This includes medical, surgical, cardiovascular, renal, hepatic, oncological, transplant patients, and more, encompassing both enteral and parenteral nutrition. Upon finishing, attendees will be capable of confidently and securely formulating nutrition plans and managing any related complications. Join the fellowship to reshape healthcare and transform your dedication to patient care into a leadership role in critical care nutrition. Whether you're a beginner or a seasoned professional, this program offers the perfect platform for growth. Your path to becoming a healthcare innovator is just a step away. Don't let this chance slip away. Embrace your future in critical care nutrition with the Intensive Care Nutrition Fellowship. Your journey to becoming a healthcare hero starts here.
Assalamu alaikum. Good evening, everyone. It's my pleasure to welcome you all into our webinar this evening. We will be talking about the ready-made or ready-hang TBN in adults. We will have a question and answers tab. You can ask any question you want during the lecture, but we will discuss them at the end of the lecture. And it is truly my honor to present our special speaker today. Dr. Noura Al-Bnayyan is a consultant clinical pharmacist, parenteral nutrition leader in the Ministry of Health Second Cluster, King Fahd Medical City. Dr. Noura, the floor is yours, and good luck.
Bismillah ar-Rahman ar-Rahim, wassalatu wassalamu ala Rasulillah. Thank you, Dr. Omar, for the introduction, and thank you, Dr. Khalid, for the invitation. I am honored to speak here in this webinar. So, inshallah, in this evening, I will be talking about multi-chamber bag or the ready-to-use parenteral nutrition. To begin with, I would like to start with a question for everyone here. So if a multi-chamber bag is available at your institution, would you use it as a first-line therapy in a stable patient? Whether it is yes or no, or depend on the patient age and the clinical condition, or not sure. So at the end of this presentation, inshallah, you will be able to answer this question. It is a fact that the utilization of standardized parenteral nutrition is no longer an option because the parenteral nutrition service or the compounding unit for parenteral nutrition is not a 24/7 service, as we all know that it is only morning shift. And due to the increase of the complexity of patients and the complication of the diseases, this results in increase in the demand of parenteral nutrition. Moreover, there is a high expectation from the healthcare provider to start parenteral nutrition once it is indicated, whether it is in the morning, evening, or sometimes even at night, although we know it is not a stat medication. Moreover, there are a lot of shortages we are currently facing, multiple ingredients in parenteral nutrition component. So all of these elements emerge us all to think about the solution of utilizing the multi-chamber bag as an option at our institution. Here is the objectives for this presentation today. I will start by explaining the scientific basis of the multi-chamber bag, and then we will identify the clinical appropriateness and of utilizing multi-chamber bag. And lastly, I will be comparing the multi-chamber bag versus customized PN, looking at the evidence-based recommendation as well. So we know that parenteral nutrition is one of the most complex prescription therapy, as each prescription contains more than 20 ingredients. And the risk of parenteral nutrition, whether it is compounding or prescription, is associated with a high risk of error, contamination, and infection as well, whether it is due to the preparation process or the administration process as well. Also, parenteral nutrition by itself, it is a complex therapy associated with multiple complications. Moreover, a lot of shortages that we are facing as well, as I mentioned previously, this mandate us to utilize a standardized method when prescribing or preparing parenteral nutrition. So the multi-chamber bag, defined by the ASPEN as a standardized commercially available parenteral nutrition product that are formulated in a manufacturer, and this product require fewer compounding steps before administration. It is also recommended to avoid the use of a premixed as a terminology, as mixing and additives are required, such as multivitamin and trace element. So there are different products available in the market, differ in amino acid profile, meaning there are an adult formula and as well as pediatric formula as well. Also, there are differences in the electrolyte content, lipid as well, and whether it is a central line or peripheral line formula. So a multi-chamber bag is developed based on validated stability studies and compatibility as well. So the formulation are containing a balanced formula of calcium and phosphate amino acid as well. Also, the available multi-chamber bag contain an advanced lipid emulsion, which is the new generation, whether it is olive oil based or fish oil based, which some studies have shown that it improves the immune system and acts as hepatoprotective benefit as well. Also, it is a standardized formula that contains the average requirement for an adult patient. The formula contains around 25 kilocalories per kg per day, and it meets the age requirement as well. Also, since it is manufactured in an industry, so it is a sterile, shelf stable for up to 24 months in room temperature. And so when to utilize the multi-chamber bag parenteral nutrition, the guideline recommend using multi-chamber bag for hemodynamically stable patient who require the maintenance requirement of fluid, meaning they are not in fluid restricted or require a double maintenance. Also, it is an option for those patients who required an immediate nutrition support, and for those hospitals that they don't have a compounding facility. It is also an option for a peripheral hospital where they don't have an even IV room at their institution, and they are contracting with outsourcing manufacturer. So this can be used as a bridge until the customized parenteral nutrition is available. So on the other side, the customized PN is still preferred and to be used for complex metabolic disorder patient, for neonates, patient with organ failure, such as renal or hepatic disease patient. So each patient needs to be assessed and evaluated and implement appropriate clinical judgment before initiating multi-chamber bag parenteral nutrition. So this scheme is adapted from the Aspen guideline, where they utilize it as a decision maker for multi-chamber bag. So once the patient by default require parenteral nutrition, by default should be started on multi-chamber bag. However, if the patient is in extreme fluid restriction or have an electrolyte imbalance, whether it is a restriction of electrolyte or require a multiple boluses, patient with high calorie need or protein restriction, unique fluid requirement. So if one of those elements, the patient will require then a customized parenteral nutrition. So this is like a helpful tool for the prescriber to utilize it before prescribing customized PN. And here is a clinical scenario as an example. So a 65-year-old adult patient post-major abdominal surgery, NPO for 5 days. The patient is hemodynamically stable with normal renal lung function test. There are no major electrolyte abnormalities and no history of severe malnutrition, meaning is not at risk of refeeding syndrome. Compounding unit is closed and the customized PN will not be available until the second day. So if a standardized premix adult available, would you use it? So here is the option: to wait for customized PN, start multi-chamber bag PN, or delay, start peripheral PN. Can you answer in the chat, please?
We have one answer, Doctora, and they say B. I think the majority of answers are saying B, multi-chamber.
Okay. Oh, thank you very much, Doctor. Sorry, I thought there is an access to the chat. Okay, excellent. So the answer is B, since the patient is hemodynamically stable, no major electrolyte abnormalities, then this patient is eligible for multi-chamber bag. In this table, you will see a summary of a comparison between the multi-chamber bag and the customized PN. So multi-chamber bag is ready-to-use formula. It can be activated within a few minutes. It is as it is manufactured in the GMP. So this is a validated sterility testing implemented, and as I mentioned, it is stable for up to 24 months. It is associated with lower risk of errors and infection. However, it is a fixed formula, as we said. And when we looked at the cost, it is cost effectiveness, and it is only applicable for stable patient or patient stable as well on home parenteral nutrition. However, when we compare it to the customized, where it requires longer time for preparation, the sterility testing, it depends on the IV room facility and the staff aseptic technique implementation. Compared to the premix, it is associated with higher error risk because of the multiple manipulation and calculation. However, the advantage that it is fully customized can be tailored on exactly the patient requirement, and it is best used for critically ill patients, and it is considered more expensive. Now let's review the practical and clinical consideration for the multi-chamber bag. When we talk about the practical and clinical consideration of multi-chamber bag, we focus on 3 elements: safety, cost, and clinical. And this is very important to be assessed even at your institution when thinking about the addition of the multi-chamber bag. So we will discuss each element. As far as safety, we know that multi-chamber bag considered relatively safe due to the error reduction and the reduction in the bloodstream infection where the study have shown. However, studies also have shown that another type of error is associated with multi-chamber bag, meaning error in volume calculation or additives missing to add the multivitamin or trace element. Sometimes even failure to activate the bag, as the bag is containing 3 chambers, so it has to be activated before administration. On the other side, the type of error reduced in ordering process or in the compounding process as well. On this study, I will be sharing with you, this is one of the well-known study that they investigate the differences between the bloodstream infection rate associated with 2 different parenteral nutrition formulation, the customized and the multi-chamber bag. And you will see that in this study, a total of 406 patients enrolled in this study, 202 in the multi-chamber bag and 204 in the compounded bag. As you can see, COM2 and COM1 is only the differences in the type of lipid emulsion used. The author concluded that the bloodstream infection associated, 34 patients had bloodstream infection with a multi-chamber bag. However, in the compounded group, 46 bloodstream infection. So they found that the rate of bloodstream infection were higher with the compounded parenteral nutrition, and they concluded that compounded PN was associated with a higher incidence of bloodstream infection and CLEPSI, and therefore they suggest that the use of multi-chamber bag may play a role in the reduction of the risk of infection. However, this is very important to highlight, and even it was highlighted in the same study, that the reduction in bloodstream infection can be only seen in those hospitals that they implement a minimal manipulation of the bag, meaning not to add multiple additives in the multi-chamber bag. So let's say you are adding only multivitamin and trace element. However, multiple manipulation on those bags may again associated with the risk of infection. On the other side, that the implementation of good sterile technique and following the USP 797 recommendation, meaning that the bag shall be activated in IV room under USP 797 standard. And this is another study that published in 2022, where the objectives of the study is to compare the incidence of central line infection in home PN patients receiving customized compared to the multi-chamber bag. This was a retrospective observational study involving 2 patient cohort group. So this study focused only on home PN patients, and they looked at a total of around 105 patients, 45 of them on customized and 60 in multi-chamber bag. And they found on both group the risk of central line infection were the same. And when they looked at the group that they were switched from the customized to multi-chamber bag, total 18, they found that before with the customized, it was 2 incidents. However, post-implementation, it was 1. So the author here concluded that the use of the multi-chamber bag in home PN patients was not associated with increase the risk of bloodstream infection. As we know that for home PN, the bag is activated at home, so it is not under a sterile environment. And this study will help the international guideline and provide reassurance for the continued use and safe of the multi-chamber bag home PN. So now the question here, if you are working in a tertiary care hospital with a 500 bed capacity, and the major specialty in this hospital is adult oncology and surgery, average PN order per day is 20 per day, would you consider the addition of multi-chamber bag? So again, when we assess, we have to look at the safety, cost, and clinical. So we have reviewed currently the safety, and let's see at studies that cover the cost issue. So when we calculate the cost, it is very important to know that to know if it is a cost effective for your institution. First, we need to know whether the PN is performed in-house or outsourcing, as the cost of outsourcing is different than the in-house preparation. Whether you are going to utilize multi-chamber bag 3-component or 2-component. So 3-component meaning it contained amino acid, dextrose, lipid. The 2-component containing only amino acid and dextrose, meaning that you need to infuse lipids separately. Therefore, infusing the lipids separately will add a cost on the tubing set. So again, we need to look at the tubing set cost of the automated compounder, nursing and pharmacy time, additional electrolyte boluses if using a fixed multi-chamber bag. This is also a factor. Therefore, I will be sharing the studies that looked at the cost. However, cost will differ from hospital to another, depending on the current practice. So this study was published in 2020. They looked at they evaluate the PN preparation time and resources utilization for multi-chamber bag. And this study, they concluded that commercial multi-chamber bag reduced the staff time by 62%. And this is logically, because we know that compounding step or process is almost reduced by 80%. And also the direct cost by 37%. So the result of the study demonstrate that the multi-chamber bag offer a potential cost saving for hospitalized patients. So again, when we go back to our case, the adult oncology and surgery, we know that can be used safely. It is considered cost effective. However, let's look at the clinical benefit. So when we look at the clinical evaluation for the addition of multi-chamber bag, we look here at 3 factors. Frequency of shortages. Are you suffering from shortage? Macronutrient and micronutrient consideration and requirement of your patient. The shortages, it is a worldwide, not even in our region. We always suffer from amino acid shortage, phosphate acetate shortages. And it is also always reported in the Aspen website, a report that it is updated in a monthly about the product shortage. So we know that product shortage in parenteral nutrition is a chronic issue. Another clinical consideration, which is the macronutrient requirement. So when we look at the utilization of multi-chamber bag, we need to assess the patient condition, whether a low protein required or a high dextrose. Patient is requiring a high protein, hypocaloric diet, whether it is for obese patient, acutely ill patient with liver disease, renal disease, or severe congestive heart failure, where they require a fluid restriction. The micronutrient consideration, which is the total volume, fluid overload. So if the patient are at risk of fluid overload, meaning we need to have a very concentrated parenteral nutrition. If the patient is having severe electrolyte imbalances, which is difficult to be managed through the multi-chamber bag. So back to our case. If a tertiary care setting hospital with a 500 bed capacity, specialty adult oncology and surgery, meaning the average age is those patients usually are not suffering from renal or liver disease, and there is a huge considered a big number, which is 20 PN per day. So the utilization of multi-chamber bag would be an excellent option for addition. However, if you are working in a tertiary care hospital with the same bed capacity, however, this specialty focusing on critically ill and cardiac patient, you have only 10 order of PN per day. So for this specialty, we need to assess whether the addition of multi-chamber bag is optional. Is it clinically relevant? So for those patients, an assessment need to be implemented before utilization. So now, implementation of the multi-chamber bag. At first, before the decision of utilization of the multi-chamber bag, a cost analysis type of service, meaning we can do a drug use utilization of parenteral nutrition. Let's say we can retrieve the data of 6 months back, review the number of patients, review the orders, specialty, patient condition, and then decide whether it is an option. And also the product selection is depend on the retrospective evaluation of your parenteral nutrition order. So you will decide whether a central or peripheral PN is needed. How many volume would you have? So always the volume selection must be decided based on your drug use evaluation, and also reviewing the number of additives that can be added to the multi-chamber bag. Most importantly, to have an policy in place where it clearly defines the clearly defined the process from procurement until administration, also to set the total number of additives, and if there is any system change, meaning in the ordering process or in the compounding process. And then also to implement a proper training and for ordering, verification, preparation, and administration before implementation. So when prescribing multi-chamber bag, those are the elements that need to be included in the prescription. First is the formulation itself. Those formulations should be prescribed in a brand name, not only multi-chamber bag, because each available brand contains different ingredients, different concentration. So the formula, the order should include the name of the multi-chamber bag, the route, concentration, and the volume. Also, there should be a tool help the prescriber once they prescribe the amount of electrolyte will appear. So meaning if you do have a standard 2,000 liter multi-chamber bag and the order is to infuse only 1,500 ml. So a calculator or a tool in place has to be implemented to help prescriber to know what is the exact amount of electrolyte that the patient will actually receive. And then the ordering should be in amount per day, electrolyte for any additives to be described in a salt format, and as I mentioned, brand identification is essential. Also, we should include in the pharmaceutical review process, once the order is in place, then the pharmacist will review the order. The pharmacist must review the calcium and phosphate. If there is any additives added, we should check if there is any risk of precipitation, and the manufacturer is always providing the maximum additives that can be added. So this should be included in the policy and implemented in the system to avoid any errors. Before addition of any ingredient, we should consult the manufacturer. So this is an example on the additives. So if you do have a multi-chamber bag 1 liter, and the rate is 40 ml per hour, and then potassium level came today is 2.5 millimole. So the plan from the team is to increase potassium in PN by addition by adding 30 millimole. Okay, so when we the prescriber want to add 30 millimole to the TPN bag. So once we decided to add any electrolyte, we should check the brand name, concentration, and then review the manufacturer recommendation. This is an example. The patient is on 1 liter, 1000 ml. We want to add potassium. The bag includes 30 ml, but we want to add additional 30. So we go to the maximal further addition. So the maximal further addition is 120. So we are safe to add 30, right? So this is step 1, to check if you can add this dose. So here, yes, we can add 30 millimole. Another example is that if the patient on multi-chamber bag rate is 65 ml per hour, meaning total volume of 1,560 ml per day, potassium again 2.5, the team wants to add 30 millimole. The available multi-chamber bag is 2 liters. In the previous example, it is 1 liter and the patient will take 2 liters. Here, the patient will take only 1,560 ml from the bag. So let's review. How can we calculate? So we need to add 30 millimole in the actual volume that will be infused, which is 1,560 ml. Okay, but we have 2 liters. Then, using X and Y method, so I want 30 millimole in 1,560, how much will be in 2 liters? So the pharmacist must add 38.5 millimole. This is again a tool in place required to help the pharmacist calculate the addition, because the prescriber will add the amount that it is required for the patient. So the addition, the pharmacist will add 38.5 millimole, and then meaning 30 millimole will be in 1,560 ml. So now let's move to the PN multi-chamber bag preparation. So the bag must be activated, additives must be added in a laminar airflow hood in the pharmacy under a condition that compliant with USP 797. Also to dispense the multi-chamber bag volume that most closely appropriate to the daily volume requirement. So if the patient on 900 ml, we dispense 1 liter. If the patient on 1,600, we dispense the most closest, which is 2 liters. Additives include vitamin, trace element, and electrolyte, most importantly, in according to the manufacturer recommendation. And this sheet is adapted from the ASPEN, where a competency test must be in place for all pharmacists who deal with a multi-chamber bag. So the pharmacist must identify the correct product and volume, inspect the product for any damage, and know how to completely activate the bag, able to identify any inappropriate additives, and know how to completely affix patient-specific labels, and know the process of refrigeration and delivery. And then lastly, the label consideration for the multi-chamber bag. So the PN label must match the PN order, which should include the volume, the brand name, and any additives that added. Also, the complete name of the product plus the name of any additives in a salt format. And as I mentioned, all electrolytes must be added in a salt format. So to conclude, the multi-chamber bag parenteral nutrition is, as we have seen, that it is considered an evidence-based, safe, and pharmaceutically superior in terms of stability and sterility. However, it is still not a replacement for the customized PN. It is considered a clinical strategy option that can be used in the right patient at the right time. Multi-chamber bag help us to enhance the access of the parenteral nutrition, reduce error, and support continuity of care in a hospital and home setting. Thank you very much. If you do have any question, please let me know.
Thank you very much, Doctora. This was truly a great lecture in a very important topic, I think. These are much needed, as you explained. Sometimes we don't have the facilities for complex IV admixtures, or sometimes we need them for the sake of time. We have some questions from the audience, but if you allow me, I would like to just, for my own information and the attendees, I have few questions of my own. So you showed in the beginning of the lecture decision to start multi-chamber or mixed TBN, and you said it's from the Aspen. Is it like a guideline recommendation or just general guidance?
It is general guidance. The
Okay.
guideline recommend whether it is Aspen or Aspen.
Mhm.
They recommend to utilize standardized PN
Okay.
due to the risk of errors in preparation and prescribing. And this decision that charted that I have that you have seen in the slide, this is adapted also from the Aspen, where they make it as like a tool where the hospital can utilize if they want to implement a multi-chamber bag.
So I should first consider ready-made or multi-chamber, then go for like tailored TBN,
Yes.
right?
Yeah, if you tell you know the guideline recommend always to use standardized PN. Okay. So in order to successfully implement the utilization of multi-chamber bag, it is recommended to make it like a standard. Whenever any patient require PN, at first think about of multi-chamber bag. If it is contraindicated or patient not eligible, then go to customize.
Okay.
You understand
This
me?
actually, yes, but this takes me to another follow-up question. I've seen in some hospitals they have their own pre-mixed, and I think the term here is correct. So they have their own standardized only with macronutrients, protein, lipids, and carbohydrates in small doses, and it is already pre-mixed with a beyond use date or expiry date of 1 to 3 days, and it's available to be handed off during evening or night for cases that need them, in case they miss the deadline for TBN or anything. So I know it's a little bit outside of the scope of this lecture, but what do you think of this practice?
Yeah, I have seen this as well. You know, this is considered as standardized PN because if you want me to define standardized, it could be an institutional standardized PN or manufactured standardized PN. The manufacturer standardized PN, this is the multi-chamber bag, where it is comes from the manufacturer. However, there is also an option for institution to make their own institutional standardized PN. If you ask me about, you mean my opinion in reducing the error, it will reduce definitely. Yeah, if your aim is to reduce the error, save the time of your staff, you do have shortage of staff, this is an excellent option. However, we also need to assess the patient condition at this hospital. For example, if the hospital is mainly dealing with a stable patient, and not surgical, I mean stable patient, not an ICU patient, then this is an excellent option. However, if the hospital focusing or the main specialty is critically ill patient, then utilizing standardized PN maybe is not a good option.
Excellent. Thank you.
So what I'm describing, maybe it is like a personal, or I mean from my experience in clinical practice. So the practice of having an institutional standardized is a well-known, and there is no issues with it.
Excellent. Thank you, Doctor. My last question is, you showed an example of how like the manufacturer give you maximum amount of electrolyte you can add. So can I add the maximum phosphate, for example, without touching the potassium, or the maximum potassium without touching the phosphate? Or if I add one maximum, I need to add both maximum?
No, you can add without touching. Yeah, I mean, you can, if your patient require calcium, you can just add the calcium, but we should not exceed
Without
the
phosphate?
yes, without phosphate.
Excellent.
Yeah. Most importantly is not to exceed the maximum recommendation by the manufacturer.
Excellent. Thank you, Doctor. Now we have a few questions from the audience. So one question is about, you mentioned the electrolyte boluses. Could you elaborate more? Like, do you mean correction of electrolyte abnormalities with peripheral separate IV line other than the TPN, or what do you mean by electrolyte boluses?
Exactly, doctor. Meaning as the administration of boluses separated from PN. So this is a cost because a multiple biggie bag will be prepared. In addition, it is a time consuming for the pharmacy to prepare or the nurse to administer. So this
Excellent.
is like a cost.
Yeah. You mentioned that we round the volume up to like 0.5. And in the, I think one of the examples you said 1.5 liters, we go to 2 liters. I think the question here is, what do we do with the 0.5? Like, do we give it to the patient?
Discard.
Or?
لا, discard. Therefore, you remember the example that I have shown you with the potassium? So
yes.
We will add 38 millimole, although the patient will take only 30, because we know that the remaining 8 millimole will be discarded.
Excellent.
I'm not sure if I'm explaining it correctly. Did you understand?
Yes, it's clear. Yeah, it's clear. The question was actually asking, do we discard the extra volume? So you answered.
Yes.
We have a few questions, Doctor, I think slightly outside of the scope, but feel free to answer. If the patient is suffering from mental issues, then we can prescribe multi-chamber or not? I think if they are not posing a risk of like pulling the lines or harming themselves, I don't see any issue, right?
Yeah, if there's any issues like this is multi-chamber bag is similar to customize in terms of patient's mental condition. So no differences. If the patient have any is already on customized and you want to shift him or her on multi-chamber bag, it is fine. There is no contraindication for it.
Last question is a little bit. So I think they're asking about the indications for IV nutrition. They're saying we give formula by mouth generally, but in what condition do we have to use IV method?
This is mainly the indication of parenteral nutrition. Parenteral nutrition is indicated when EN is not an option. So if the patient cannot take orally or enterally, then we give parenteral therapy.
Another question is, do we add vitamins when needed? And what vitamins do we need? I think the multi-chamber comes already with the required daily amounts, right, Doctor?
Multi-chamber bag contain daily requirement of the calories, but does not contain multivitamin or trace element. Therefore, they must be added before administration.
Excellent.
Separately, a multivitamin or trace element will be added.
Thank you, Doctor. We'll wait a little bit for if anyone has any questions for Dr. Nora. One question, Doctora, just from my own practice and just curiosity. If we already have the facilities, we have already the IV room, we have the hood, we have the qualified staff, and we do like yearly competency and everything. Is it still cost effective or to have a multi-chamber or?
It depends on the number of parenteral nutrition orders. So if you do
Okay.
have a huge number of PN, then definitely it is an option. It is a great option even. Because even if you do have a well-standard IV room and you have staff, the multi-chamber bag is considered faster, reduction of cost
Yes.
and time. So it is an option. It is a great option. It depends on the number of parenteral nutrition order at your institution.
One last question here we have, Victoria, is which trace elements and vitamins should I add, or do you recommend to add?
In my practice, we have used all the available products, which is registered here in the Saudi FDA, whether it is from Baxter manufacturer or Verzinia Scapi, all of them can be used. There is no I'm talking about our personal experience. However, always when we buy or we have a multi-chamber bag, we always refer to the manufacturer recommendation. But from our experience here, we use both brand, no issues.
Excellent. We have a question here you already answered in the lecture, but so they have the full information. They're asking if I don't have IV room, if I don't have the facilities to make it like tailored or customized TBN, what do you recommend? I think this is one of the biggest selling factors of multi-chamber TBN, right, Doctor?
Right. يعني, you mean if there is no customized PN?
Yes,
the
they cannot make. Yeah, they can't. They don't have TBN facilities.
Yeah, definitely multi-chamber bag is an option.
Now, our last question for tonight is that they're saying one of the challenges of ready-made or ready-to-hang TBN bags is the fluid restriction. So, you have any input on that, or you have any opinions? If the patient is fluid restricted, should I just totally avoid the multi-chamber, or is there a way I can work around it?
This is, I would say, if I will answer you theoretically, I will tell you yes, avoid.
Okay.
However, when it comes to practice, sometimes we do have shortage, and the only option available is multi-chamber bag. Then the decision will be, I will assess the patient, see the requirement, and give even the minimal requirement through the multi-chamber bag. So the answer is that we have to assess the patient.
Excellent. Thank you very much, Doctor. It was a really great session. Thank you.
Shukran.
And thank you everyone for attending, and special thanks to the organizing committee.